Welcome to This Week in Health IT, where we amplify great thinking to propel healthcare forward. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcast videos and collaboration events dedicated to developing the next generation of health leaders. If you missed our live show, it is only available on our YouTube channel. What a fantastic conversation we had with Director for David Muntz, Sue Shade, around what's next in health IT. You can view it on our website with our new menu item, appropriately named Live, or just jump over to the YouTube channel. And while you're at it, you might as well subscribe to our YouTube channel and click on Get Notifications to get access to a bunch of content only available on our YouTube channel. Live will be a new monthly feature only available on YouTube. How many times did I say YouTube in that paragraph? Subscribe to YouTube. We're going to have some great stuff over there. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. They reached out to me to see how we might partner during this time, and that is how we've been able to support producing daily shows. Special thanks to Sirius for supporting the show's efforts during the crisis. Now, on to today's show. All right, this morning we're joined by Dr. Ben Kanter, a pulmonologist by training and CMIO for Vocera Communications. Good morning, Ben, and welcome to the show.
Good morning, Bill. Thanks for having me.
We have that delay going. We're getting used to this world of Zoom that we're all living in. I'm looking forward to this conversation. Communication is extremely important normally within a hospital, within the health community, but during a pandemic, that is really magnified. So let's go ahead and dive right in. How have systems been utilizing technology to support communication?
Yeah, you're absolutely right, Bill. The need to keep your staff safe, the need to keep the patient safe has really accentuated the complications of communicating, particularly if you're wearing PPE. So that was and has been an ongoing challenge. And it's not unique if you think about it to healthcare. First responders, let's say firemen, they need to be able to communicate with the rest of their team. Folks that are on a battlefield, soldiers, they need to be able to communicate. And you certainly wouldn't expect your soldiers to have to stop what they're doing and take off their protective equipment in order to do communication. And so the same thing holds for our first line folks in healthcare. The physicians and nurses who are taking care of patients really shouldn't have to doff their PPE if they're going to have communication.
Yeah, so what have the solutions looked like? I saw in one of your blog articles you guys had caregivers shouldn't risk contamination for communication. So how do we get around that? How do we give them the opportunity to communicate with patients, with each other, without taking that protective equipment on and off?
Yeah, so let me just highlight the difficulty of taking off your PPE correctly. It's hard to do. It takes time. You have to be really vigilant. And physicians and nurses, the last big study that I looked at, showed that roughly 40% make errors when removing their PPE, and that significantly increases the risk of self-contamination. If you self-contaminate, not only are you at obvious risk, but you become this unwitting vector for ongoing infection within your organization. So the key then is to minimize, first of all, the need to put on your PPE in the first place. So how can you enable two-way communications with a patient, even if they're not in a traditional patient bed, right? In this pandemic, we've got patients that are in pop-up beds, if you will, temporary beds that may not have a standard nurse call. So how do you enable two-way communication so that the nurse or the physician can talk with the patient without having to put on PPE in the first place to get into that room? Secondly, if I'm in the room, what I really want to be able to do is communicate in some manner externally without having to take off my PPE. And so for that, with Vocera, we have our traditional badge that I'm wearing. We have our smart badge, which is right next to it. These can be worn underneath PPE. And underneath PPE, they still give you the full access to all the communication channels. So whether you're calling one person, calling a group, calling your command center, need to reach the COVID intubation team, you can do all of that from one of these devices underneath the PPE. That's
interesting. I mean, obviously the risk for contamination being what it is. But my question is, has the communication changed fundamentally as a result of the pandemic, or has it just changed the way we're doing it because of the need for PPE throughout the entire system?
I think it's more the latter. It's really changed the manner in which we can do it safely. So, before the pandemic, leaving a room and picking up a phone would not be thought of as a dangerous thing to do. But it's dangerous now. It's dangerous. And so minimizing the need to use multi-use devices, where people are sharing devices, is important. So I think it's more the latter.
Well,
but communication in this setting is as important as ever, because you've got to deal not just with the patient and the care team, but how do you move the patient efficiently through your hospital? How do you handle the surges? And you can't manage a surge. You can't manage throughput without communication.
Yeah, normally when we're doing this kind of thing and we're rethinking this, we spend a lot of time on policies and procedures leading up to this. Now, obviously, we did an awful lot of work in a very short period of time, and I've heard some really creative, almost MacGyver-like solutions that people pulled together and did some amazing things. Do you think will we now go back and update our policies and procedures, and are we gonna see that happen? And do you think coming out of this that people will rethink their communication platforms?
I do, and you're right. There's nobody more creative than the frontline nurse who is stifled from doing his or her job. They will figure out a way to get something done, whether it's through the use of things like baby monitors or other off-the-shelf solutions. If you think about PPE, gloves, masks, face shields, technologies have been around a long, long time. But gloves started out as sheep intestine. We don't use sheep intestine anymore, right? And the masks that we use are not just simple cloth, they're polyester, N95s. And so technology has evolved. And I think that we're going to see communications technologies, hands-free technologies, become really an integral part of PPE moving forward. Yeah, so that's one major shift.
Do you think there will be a lot of policy work that has to be done and how we think about it? And so what I hear you saying also is that hands-free communication will probably become the norm. There's no reason for it not to become the norm throughout the entire health system.
Right. Yes. And I do believe that things are moving that way. There's a time and a place where you have access to your hands, where you have access to a smartphone. There's a time and a place where you need to be hands-free, whether that's in an isolation room under PPE, or it's in the OR, or you're doing a procedure. So hands-free and using the voice interfaces the way that we've become used to in our commercial devices over the past couple of years is really the future. So voice-driven actions are going to be key. As far as policies and procedures, it's an interesting question because as smartphones have come into use in the hospitals, there are now more and more ways to reach people, whether it's by text, voice, SMS, video, etc. Each of these modes of communication brings with it advantages and disadvantages. So for example, if I'm trying to communicate with you and it's a large volume of very highly contextual information, it's probably best that we have that discussion like we're doing today, some kind of synchronous communication. If it's a small, short message that's not very intricate, perhaps a text message is appropriate. Some of these message modalities are more interruptive than others. So it's actually made the communication environment more complicated, not simpler. In the old days, I either walked up to you or I called you. So you do need policies today. You need policies that guide what are the appropriate uses of certain technologies and inappropriate. I'll also give you one other important example. In health systems, there's a policy that defines the electronic health record as your gold standard place for all patient documentation. There's probably 150 different options for secure texting. I mean, I could literally build a secure text solution. If that's all I wanted to do, build an isolated secure texting solution, I could build that in my garage, in days, literally. I've done that. You need to have a top-down solution that says, look, for our enterprise communication and collaboration, here is the system that we will all be on. Because if you have your doctors on one system, your nurses on another, administration on another, respiratory care on another, they're not truly communicating and they can't collaborate. So policies regarding communication in general are going to be very important.
You know, it's interesting. So I'm asking the question, and you've been great at not doing a sales pitch, but I'm going to ask the question because it's been a while for me. I was a CIO. It's been about 4 years since I was CIO. We had Vocera in a couple locations, and you almost just described what we had. So we had 16 hospitals. I think 3 of the hospitals were using Vocera, but each individual nursing community or care community just decided what communication platform they were going to use. And it did create, from an IT perspective, created all sorts of challenges from our perspective, but it also created challenges from their perspective. And they were constantly coming back to me saying, hey, can we integrate with this? Can we do this? Can we do that? Give me an update on Vocera. I assume you're talking more like a platform for communication across the entire hospital today, as opposed to a point solution, which is what I was dealing with maybe 4 or 5 years ago.
That is exactly right. We have become a full-fledged platform. We are the communication and collaboration hub for the organization. So if I were to describe our system, at the centerpiece of the Vocera offering, our secret sauce, if you will, is our ability to, first of all, integrate with up to roughly 150 different hospital systems, aggregate that information in our system, and we can bring disparate data from different systems together, write rules around it, so we can take information, from example, from your ADT system, from your alarm system, from your tele system, from your lab, from RAD, from wherever, bring all those pieces of information together, write rules around it, and then act. So we can then escalate those messages, and we don't care what the endpoint is, whether it's our device or whether it's a smartphone using Android or iOS or a tablet or a desktop. We then can message that out. If it's not accepted, we can escalate those messages to 1 or more people. We have essentially an unlimited ability to do that with tremendous flexibility. And then all the audit and reporting is on that same platform. So we become a hub for all of the voice, all of the text, all of the alarms, the alerts, all of that flows through our system. And then since we're agnostic as to the end user device, we don't care whether that nurse or physician are using a BYOD, whether they're using a badge, or whether they're switching between the devices. It doesn't make any difference. So then in our directory, we not only can show who's acting now, we have all of the presence information. And so you can tell at a glance, for example, if I'm a physician, I can look up a patient on my app and I can see in real time who are the nurses that are caring for this patient right now, who's available, and immediately reach them. It's very simple things like that that gives a lot of power to the end user.
One of the things that we've been talking about, and we've had some CFOs on talking about the financial challenges that health systems are going to be facing, at least for the foreseeable, next year or 2 years coming out of this. And so we talk a lot about platforms in IT, and I think one of the things about it is the ability to automate, right? So we take a bunch of touch points out of things. That's one of the things that platforms do, and they also put the security layer around the whole thing, so I don't have to think through security on this one, security on this one, security on passing the information. Talk a little bit about the automation that is available on your platform.
So I'm going to go back to something you just said a second ago, and that is, there's, with a platform like ours, one of the goals of communications inside healthcare is to try and minimize delays or drop communications, right? Communication inefficiency is a problem for the hospitals, and it's a major cause of sentinel events. Virtually every system you place in a hospital today has an ability to send alerts or alarms directly to someone. So with the best of intentions, a lot of those alarms now route directly to the nurse carrying a smartphone. and I just call it a perfect storm of good intentions. You now have all of these various systems that can ping the poor nurse. And so the nurse ends up spending his or her shift handling issues that are coming to her directly on the phone. When in the past, that didn't used to happen. Many of those calls went, for example, to the clerk on the floor who would then do the triaging and route those. So nurses were getting interrupted a lot before we ever put a phone in their hands. So you have to be really, really careful about how you automate these processes. There is, I think, a really good intent to minimize the delays in communication and route things to the staff, but there's a limited amount of bandwidth that people have, and they've got to be able to have time to do patient care without getting interrupted. So everybody's familiar with alarm fatigue. We really talk about interruption fatigue. How do we orchestrate? How do we mediate the needs to reach that same person with different information? And it's getting more complicated over time. It's not getting easier. So just putting a smartphone in the hands of your staff does not make things better for them. It can paradoxically make things actually more difficult. It's how you orchestrate those calls on the back end that's really key, and that's what we do. We're a workflow orchestration platform.
So my last question coming out of this is, are there best practices around doing that to avoid alert fatigue or I don't know, transition fatigue between priorities and those kind of things, so people aren't constantly changing their focus?
Yeah, I think there are. So for example, if you're going to automate an alarm that's going directly to your staff, I think it's incumbent on the IT department to set up those alarms ahead of time and then monitor them, sort of mirror them before bringing them live. How many alarms, how many interruptions per nurse, and you can set up metrics, for example, alarms per patient per shift. How many are coming in, and monitor that before you ever turn it on. There's nothing worse than saying, okay, we're going to set, for example, let's say we decide that we're putting in a tele system and I want to pass all of my atrial fibrillation alarms directly to the staff. We know that the false positive for telemetry alarms is in the 90s. The vast majority of telemetry alarms are not actionable. You'll absolutely, destroy your nurses with interruptions if you do that. Or the same thing with oximetry alarms, basic unedited oximetry alarms. Just passing them all to the nursing staff is a road to disaster. So you need to turn on these systems ahead of time, monitor them. So that's one important part. A second best practice is to have a clinician be the mediator between, for example, your nursing staff and the IT department. You want a trusted nurse leader, a nurse informaticist ideally, who is that go-between who can work with the nursing staff to adjust the alarm threshold parameters, the enunciation delays, and other things, so that again, by the time the nurse gets an alarm or a message, it's highly likely to be true. The positive predictive value is to be high. I think a third is to integrate your communications platform, particularly if you're going to be passing alarms and interruptions, with your alarm management committee. It's a great role to have your multidisciplinary alarm management committee take ownership of a lot of these policies and practices. I want to close with one last question, and this is mostly, you're a pulmonologist by training, and just what do you think, just personally, what do you think the most lasting impact of the work that we've done in healthcare will be coming out of this crisis? So my analogy is if you're alive long enough to remember when the guy was poisoning the Tylenol bottles, before that you could open up any jar of food and you had immediate access to the food. None of these safety layers were there where now you have to peel off that paper after you unscrew the lid. That has become the norm. What today is the exception becomes tomorrow's norm. So the way we're using PPE, this requirement for communication, that's going to change. I think we're going to accelerate. Obviously, we've already accelerated our move to telemedicine. We probably did 5 years of telemedicine evolution in 5 weeks. It will never go back. Telemedicine is here to stay, and here to stay in a much wider swath of medical practice than ever would have been envisioned. So that's not going to change. I think the recognition of the dangers that our staff go through when caring for patients with infectious disease is something that, is sort of like normalization of deviance. We all recognize that it was there. When I worked in a highly resistant, multi-resistant TB clinic, there was no treatment for the diseases we were treating. If we had been contaminated, it would have been, really life-threatening. We just accepted that. I think there's now a better recognition that we need to protect our healthcare workers, to the utmost. I don't think that's going away.
I remember that Tylenol scare, and that was really scary. And they responded very quickly to that.
I lost your audio.
Oh, you did? Sorry about that. I can still hear you great. I really appreciate the analogy around the Tylenol. The exception from yesterday will be the norm moving forward. I think that's what we're going to see. That's all for this week. I really appreciate the time, Dr. Kanter. Thanks for coming on and talking about communication during a pandemic.
My pleasure, Bill. I appreciate it, and happy to do this again in the future. Thank you.
That's all for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, HealthLyrics, Sirius Healthcare, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, the best way to do that is to share it with a peer. Send an email and let them know that you value and you are getting value out of the show. And also, don't forget to subscribe to our YouTube channel while you're at it. Please check back often as we will continue to drop shows until we get through this pandemic together. Thanks for listening. That's all for now.